my first talk will be regarding the transscleral fixations of various techniques.
1 second, Sunil. Each presenter will have 5 minutes for presentation and 2 minutes for discussion.
Sure, sir.
Okay.
Thank you, sir. So basically, I'll be talking to you regarding the various techniques of transscleral fixations. Various options are available with different IOLs regarding in a patient, whether it's a dislocated IOL or with aphakia. So among them, today I'll talk about the no glue, no flap, and the no suture technique of IOL fixations. As we know that scleral fixated and glued IOL has got its own share of complications and side effects, probably suture-related astigmatism, suture-induced erosions, and suture degradation. For the glued IOLs, cost is an issue. So we thought of on newer techniques. The many techniques have been described. Basically, in these techniques, the surgical time is reduced, the refractive correction is better, astigmatism is less, and you don't require a glue for this. So basically, what you require is a 3-piece IOL for this. Either could be rigid or a foldable IOL, and you may require a 26 or 27 gauge needle and a forceps for grasping the thing. So indications for these sort of IOL is either aphakia, subluxated, or a dislocated IOL. I'll show you my first technique of doing the thing, where you open a conjunctival opening on horizontal meridian at 3 o'clock and 9 o'clock. So mark the diagonally opposite points. The Mendes marker, this thing's 3 o'clock, 9 o'clock is marked. So you make a partial thickness groove on either side. So you make a scleral pockets using a bent keratome, or you can use a needle also along the track of the scleral groove on either side. So either you can use an AC maintainer, or you can use, if you're kind of well versed with a pars plana infusion, you can use the pars plana infusion also. So once you're done, you introduce a trocar through the scleral groove, do an anterior vitrectomy. So do a thorough anterior vitrectomy. Use a 3-piece foldable IOL. So put it on the iris surface, and by the handshake technique, you can externalize the haptics. So externalization is the same on both the sides. You can do the things and tuck the haptics into the, once you've done that, you can tuck the haptics into the scleral groove so that it becomes fixed there. And if you want, you can suture the scleral tunnels. So another modification is the technique which has been described by Yamne's techniques. Here also, it's a case of a dislocated IOL which has been explanted, and another 3-piece IOL was used. So you inject a 3-piece IOL in the similar way, but here we don't open the conjunctiva, or neither we make a scleral flaps or the glue. Here we just go behind 2 mm behind the limbus and 2 mm laterally along the thing. Bent 26 gauge needle or 27 gauge needle can be used. Similar by the handshake techniques, just incorporate the haptics into the needle. Keep it there, don't externalize it in one go. Similar manual can be repeated on a diagonally opposite point, 2 mm behind and 2 mm apart in the horizontal meridian. Once you engage both the haptics through the needles, you can just externalize both the haptics. So you cauterize the tip of the haptics once you externalize both of them, and then insert into the scleral groove, which are the pockets which you have created. So similarly, instead of needles, you can use the trocars for the externalize of the haptics, which has been well shown by, this is Dr. Somdat Prasad has shown in one of his videos. This is regarding externalization through the, you can use the trocar for externalizing the haptics. Like you can pull the haptic through the trocars, trocar cannulas, and you can use the similar to the needle technique for the externalization of the haptics if you're not well versed with the needle technique. So we did on 26 eyes, most of them recovered very well vision with less good astigmatism, but the complications which we noted were few had ifema, two patients had a vitreous hemorrhage, breakage of haptic was noted in few. Post-operatively, one had a corneal striae in a couple of patients, AC reactions were noted. So glue and suture is not a must for suturing the scleral fixated IOL. It's an effective procedure for dislocated IOLs as well as any patient with a secondary IOL patients in IOL implantation FAK. You can incorporate these techniques. Thank you.